Hello, everyone. Welcome for another Tuesday VMR with a special session with POCUS. We are super excited to receive our guest. This is his first time here on a VMR, and we want to say welcome. Dr. Scott Biggerstaff is an internist and pediatrician working as an academic hospital at the University of Minnesota. He's a faculty and a director of point-of-care ultrasound education for internal medicine residents. And yeah, do you want to say hello and introduce yourself?
Yeah, that's you did. That's all the stuff. I'm I'm a med peds hospitalist in Minnesota, in Minneapolis, and I have watched some of the POCUS VMR things and some of the clinical problem solvers stuff you guys have done. Big fan. It's really cool. Excited to be invited.
Amazing. And we like when we have our guests, we like to know a little bit more about them and what do you like to do for fun? And as is Halloween, what you're gonna wear today?
Yeah, well, I'm working tonight, and so I thought maybe I'd break out the hot dog costume, and yeah, probably not though. And when I'm not working, spend a lot of time reading, hanging out with my dog. I have a black lab mix named Doug, and we do a lot of running and walking around the Mississippi here in Minneapolis. Um, and yeah, I love Premier League soccer and Kansas City sports. So I spend a fair amount of time watching those too.
Amazing. Yeah, thank you. Thank you so much. I think you can share the whiteboard and we can start.
Cool. All right. Sweet. So this is my Twitter handle, and then I have a site where it's like a Google site. I just stashed a bunch of images I got during fellowship, and I am an internist and pediatrician. I did a 1-year POCUS fellowship at Oregon Health and Science University, and I did want to shout them out real quick. They are still open for applications. If you're not sure what you're doing next year and you're wrapping up internal medicine or family practice or med peds residency. Dr. Kevin Pyro is the director, and it was my favorite year of training. That's me scanning my POCUS fellowship director's gross knee and a big old Baker cyst. So do POCUS fellowship, and you can look at Kevin's gross knee. So POCUS, I just want to go over some of the kind of basic principles first. It's limited, right? We're not obtaining like 50 views like in a formal echo. A focused cardiac exam would be like 4 or 5 views, and then kind of same with other organ systems. It doesn't replace consultative imaging. Some people say formal imaging, and then you get replies in the comments with that Winnie the Pooh wearing a tuxedo meme, because formal is kind of funny word. So we call it consultative, but like, it's I would, if I was going to order a renal ultrasound for a patient, I'm still going to do it, but the POCUS might help to kind of bump up something I do for management. It's focused, so we're answering a question. It's usually binary or graded. Does this patient have heart failure with reduced ejection fraction? Does this patient have hydronephrosis? Is it severe hydronephrosis? Is there an abscess hiding in this cellulitis? So it's hypothesis driven. You have a question going into it, and you're answering that question with the imaging. And it's relevant. So you are clinically correlating. You're the bedside provider who's doing the managing, and this imaging is informing a decision that you're trying to make. I like this image. It's from a kind of a commentary and editorial a few years back. And here at the top of the pyramid is clinical integration. So a lot of folks kind of focus in initially on the image acquisition bit at first, being handy with the probe, seeing the organs they want to see. But the hardest part over time is clinically integrating the findings. So what do you do with the images you obtain? So I'm working tonight, and I decided I was going to drag you guys into the hospital for a night shift also. And the witching hour is upon us. It's 3 a.m. Your pager goes off. there's 3 messages, and I'm going to let you do kind of a choose your own adventure here. So I'm just going to move this guy down. So we got in room 999, a distended belly, patient who has vomited a couple times and is fussy. We have in room 555, somebody that's now on 2 liters nasal cannula and short of breath. Nurse wants a duoneb. And in room 808, got a patient that's nauseous after on Dancitron, and they're asking for some prochlorperazine. Also, by the way, belly really big. So here's a little bit more about each of these folks, and I'll let you guys spend a second reading through these like kind of the small vignettes, and then you let me know. You can triage these and let me know who you want. This is a cool article that's from the American College of Emergency Physicians that you can find online, and just a quick like case by case thing for doing some bladder ultrasound and yeah, just some tips on post-void residuals and when to place a catheter. All right, let's move on to our next patient. So we've taken care of this one. Who's next? Do you guys want the 92-year-old who can't resist gas station cheese curds, or the 63-year-old with the busted hip?
I was curious about the second case because I like pulmonary, so I saw shortness of breath, COPD. The patient had passed for a fracture, so I was thinking maybe it could be a PE, was something that crossed my mind. It could be like a complication from this fracture. So yeah, I think can we go see this patient?
Definitely. All right, so this is the stuff you know. Here's some vitals for you. Little tachypnic and some labs from the day prior.
So yeah, we have a 63-year-old male with COPD, hypertension, kidney in grade 3, was admitted for after a fracture, right total, hip previous day, and orthopulmonary and home inhalator surgery and no respiratory symptoms. So yeah, we see like the blood pressure, it's elevated, and the patient has hypertension and nothing. I was thinking if he's taking his medication. The respiratory rate, it's a little bit elevated too. And the patient, like, on the ECG was normal sinus rhythm. Yeah, I like the first thing that I thought was PE. And like I think the EKG can be like, we can see like sinus tachycardia, or we can see the S1 T3 T3, but that is not super specific. I think, yeah, as we are in a POCUS VMR, we could do like a lung focus. What do you think? Yes.
I am completely agreeing with you. You are the our future pulmonary care medicine doctor here. And I will definitely start again, just like you mentioned. I don't think I will add anything else, actually. Like, do you have more information for us?
Let's see. Yeah, you go examine him, and here's what you see.
Okay, so let's see what we have. The patient is uncomfortable, tachypneic, with supraclavicular muscle use. So yeah, I would be worried about how is the saturation of the patient, if the patient has any hypoxemia. And on lungs, we don't see any findings. And then the patient has some GVP, I think might be higher without extrasound murmurs and IV with pump running. Yeah, I think, yeah, we'll check his saturation if the patient has any hypoxemia with this exam, and definitely go for some image.
Cool. Yeah. The nurse tells you that he was hanging out in the mid 80s, but when she put the 2 liters on him, he popped up to the low 90s, and that's where he stayed. And we will go, I think I arranged it so maybe we have a heart exam first. So what can you tell me about this image? And if you want, I'm more than happy to just kind of to sort of blitz through how I look at each of these images and what I'm thinking about. But if you guys want to take a crack at it, that'd be awesome.
Yeah, just to answer Dr. Ravi's question, this is a parasternal long axis, and on the top we can see the that flapping is the mitral valve, like it's flapping, but we can see that there's some what I'm seeing, it's like fluid overload because it's too much. Like when you see that flap, that means that there's too much fluid going on there. That's RV overload. That's my understanding. Please correct me if I'm wrong. And I'm
Yeah,
so
like we just had like on Saturday a class about cardiac POCUS, so we had to show our mentor that we learned something. So yeah, I remember like the rule of three that we learned that we have to have the same size of the RV, aortic root, and the LA. So that is something that we should look for. I don't know if, correct me if I'm wrong, but seems like the LA left atrium seems a little bit big, and yeah, that will be my thought.
Yeah, it's funny. So this is my heart actually. It's a normal heart, I hope. But I'd be happy to hear from the peanut gallery if there's some stuff that I need to get checked out in the future. But yeah, no, you're bang on. I think the rule of thirds is what you're alluding to. That so we have the right ventricular outflow tract here, aorta, and then this is left atrium, and they should all be about the same size. And I would say just eyeballing it, I think they are. If you're concerned about one of those chambers being a little bit bigger, you can always freeze and measure. And then I think Dr. Gigi Liu mentioned also in her POCUS VMR that one view is no views, right? That's a familiar radiology convention. So we need to obtain more views. Parasternal long, we also can see the left ventricle, left atrium, mitral valve. What we're looking for here is a nice coming together of the walls, right? That endomyocardial excursion, and then also thickening of the walls with each squeeze. So that looks pretty good. And then what we call our EPSS, or E-point septal separation, that anterior leaflet of the mitral valve, in every diastolic phase, it should flip up and hit the septum or come close to it. We use kind of a rough cutoff of 1 centimeter. So if it's more than 1 centimeter away from that septal wall, then that could be indicative of reduced ejection fraction. The real cutoff is more like 7 millimeters. That's a pretty sensitive and specific marker. So you can measure that with M mode, where you drop a line and see how far everything along that line is moving. So just eyeballing it, it looks normal to me. Again, if somebody picks up on something, please let me know about it, because this is actually a normal heart, I think. And then here's our parasternal short, and I'll just kind of run through it so we can get to some of those other images as well. But we're in sort of a mid-ventricular view. We're looking for our mitral valve where they come into the papillary muscles. I'm just maybe a little bit above where those papillary muscles are, and you can see these chordae here at kind of what would that be, like 4 and 7 o'clock. And we have our right ventricle up here. So LV is nice and donut shaped. Again, we're looking at how well all the walls come together, and the thickening of the muscle all the way around. This is a great view because you can see all of the walls of the left ventricle at the same time, whereas with the other views, you're only looking at 2 walls at a time. So you can be fooled sometimes into thinking there's wall motion abnormalities. This, I think, is artifactual over here. And then up here, sometimes you can be fooled into thinking that this is a pericardial effusion, but it likely is just a fat pad there. And then this is RV. You should have this nice curved septal shape, right? So you guys had pointed out on prior episodes that when that's flattened, that can indicate that there's high pressures or volume overload on the right side, which could be due to something like a big PE or chronically high pulmonary pressures. So we'll click through to our apical 4, and in this view, what I'm looking at is kind of the right and left ventricle relative to each other. The RV should be about 2/3 the size of the LV. RV is pizza shaped, kind of triangular. We're not seeing it super well here because of a rib shadow. And then the LV is kind of bullet shaped. We're seeing good contraction, and some other things you can do in this view would be to assess for valvular competence by putting color flow over these valves. You can also take a look at right ventricular function. So the RV is going to contract longitudinally. It moves from the base of the heart to the apex, almost like it's peristalsing. So one of our measures is called the TAPSE, or tricuspid annular plane systolic excursion. And we could do an M mode line down here to the lateral tricuspid annulus and measure that. And if it's moving at least 17 millimeters with each systolic phase, then that would be indicative of a normal right-sided squeeze and function. One way to eyeball that on the subcostal view is just to see how much east-west motion you have here at the tricuspid valve. So this view, we're in the belly. We got the liver right here closest to the probe. We're shooting through the liver, and we see RV sitting on top of that, and RA back here, LV, LA. So this is a good view for assessing right ventricular free wall thickness, and also that kind of east-west motion of that tricuspid annulus, and to get a feel for whether or not there's a pericardial effusion. And no fluid around the heart there. Cool. So I'm just gonna, so your heart exam was normal, is what it is to say. And now you take a look at the lungs and tell me what you see.
Yeah, I think we can see some B lines, and that we could think about if there's something in the heart, if could be a fluid, if could be like blood, if could be a few causes that, or pulse, a few causes that I remember that we can have. It's acute heart failure, pneumonia, pleural effusion too. That are the things that I think about it. And then there's some chat that is saying that more than three can indicate an interstitial process. Yeah, great part of shame. I didn't know that. What do you think? Yes.
Yeah, I'm completely there with you and the chat. When we see so many B lines, we have to start thinking about pleural consolidations and the involvement of upper and anterior areas in the lung. Like we have to position ourselves in like there is a process making our lungs started filling with pus, with liquid, just as Dr. Rabbit mentioned. And yeah, like maybe with all of that we are hearing with the medical history, maybe this patient, I don't know, like vitals, as far as I remember, he didn't have any fever or anything, but yeah, he might have like pulmonary edema or something causing consolidation. So let's see what else is there.
I think you guys are right on track. When I see B lines like this, so just to orient everybody, we've got lung imaging with a rib on either side. I think the ribs is like my handrails. And so I want a rib above and a rib below, and then I'm looking at the that space in between. Up here, you've got this pleural line. So there's the pleura kind of sliding back and forth as the patient breathes. You have the visceral and parietal pleura sliding against each other. And then what we're seeing here, kind of in the middle of each image is called an A line. It's a reverb artifact, and that's normal finding. So if you just see that space with A lines, That's generally indicative of well-aerated lung if you're also seeing that lung sliding up top. When I start to see B lines, my eyes immediately go back up to the pleura. Subpleural consolidations from like COVID or a pneumonia can cause B lines. And so I want to look back up here. In this image, the pleura looks a little chewed up, and over here, you notice how that line is like a little bit irregular. But here and here, not so much. It's I'm more so seeing just kind of B lines extend down, and certainly nothing like really significant as far as consolidations. So going back to our clinical history, we know this guy has CKD3. And when you came in the room, you noticed he was hooked up to an IV, and then 125 mils per hour was running. So you go back in the chart and you look to see how much fluid this guy has gotten since he's arrived. And also you're going to do your IVC assessment. Any thoughts on this one?
Oh, with that one, we learned that for IVC, we have to determine like the collapsibility and the diameter of the, like in centimeters, but we also have to completely evaluate it. We have to also see the hepatic and portal flow, like what called the VMRs. In this case, it's not collapsible at all. So I'm thinking there is also like lots of fluid, because I don't see it's pulsing, like collapsing completely. There's no like less than, I'm not really sure if like less than 50%. I will not be very comfortable saying a percentage, but yeah, like you can see the IVC and the hepatic. I'm not like just trying to like give like my localization, but what do you think, Deb?
No, yeah, I think you're totally right. Two pearls that we learned on previous episodes is the IVC should be like 2 centimeters in adults and should collapse 50% in inspiration. And if doesn't collapse, can indicate that it's a high right atrium pressure. So that would be my thoughts.
Yeah, I think, yeah, this boy is thick. This is thick with 2 C's, this IVC. It's also, it's kind of weird, a little tortuous, like it's sort of taking a right angle here, kind of dog-legged. The thing that makes me think it's distended more so than anything is how big this hepatic vein looks. When you guys look at hepatic vein in practice, sometimes it's hard to see even. But when it's so dilated like that, if we did put color flow on there, or drop like a Doppler gate, there would be evidence probably of some reflux into that, right? So flow should be blue in this hepatic vein. It should all be going away from the probe and into the IVC. And what you would see is like alternating red and blue flow probably here. Red flows towards the probe. Right, so that venous flow, it should just be dumping into the IVC, but the pressures would be so high here, it would be kind of like washing back and forth. Then you go up and you confirm what you thought you noticed on exam with the jugular vein. All right, so we have our jugular vein here a little bit more superficially, and then carotid artery just deep to that on the right side of the neck. And you're following it all the way up to the angle of the mandible, and it stays distended that whole way up. Right, and the patient will say that they're at 45 degrees. So you have a pretty distended jugular vein in a patient with a normal looking heart, and a big IVC, evidence of pulmonary edema on POCUS. And you look back at the MAR and see he's been on continuous fluid since he got there, and he got a couple boluses intraoperatively. So this guy just got flooded with fluids. So stop IVF, order furosemide. I go big with the Lasix. I don't want to second guess myself and think that I didn't order enough. And so went with 80 for this gentleman, and within a couple hours he was off O2 and not working quite so hard to breathe. There's an informative guideline from the American College of Physicians about using point of care ultrasound in patients with acute dyspnea. I think the most helpful reason to use it in dyspneic patients is to try to differentiate between a cardiogenic cause and maybe a more like kind of primary pulmonary cause. And so that was what I was trying to get at with that patient who also had a history of COPD, and the nurse asked you for a duoneb, and sometimes it's easy to just kind of order that and then go back to sleep or be on your way and send or answer your other pages. But it's important to pay attention to some of those things, especially on hospitalized patients. And then this was a cool paper from a few years back that I'll show you in just a second, but a few pitfalls with IVC. It's elliptical, it's not circular generally, and also you're not often scanning it kind of head on or perpendicularly. So there's an opportunity sometimes to kind of misalign the probe so that you're getting an idea that the IVC is thinner than what it actually is, right? So here we're cutting through the middle of the vessel. Here we're just on the periphery, and the vessel looks a little bit thinner out there when that's the case. So so that longitudinal view is challenging, and this paper looked at estimating central venous pressure using some different measures of IVC, including some short axis measurements. So as you can see, when CVP is normal, this IVC is sort of like lens shaped. And then as CVP increases, you have an increase in the short diameter relative to the long diameter. So you wind up with a more circular IVC. So for me, when I look in the long axis, I'm also now switching to the short axis view, and I'm trying to see if this IVC is really round, because that tells me that it's probably plethoric and that CVP is elevated. And you take that with all the other data that you're accumulating from the jugular vein and from the lungs and your heart exam. All right, so let's see our last patient. This gentleman just couldn't keep his hands off the cheese curds, and I don't blame him. Getting pretty hungry now too. But you got a 92-year-old with high blood pressure and PAD who's in the OBS unit for 1 day of nausea, vomiting, diarrhea. There's some vitals and labs, and you guys can kind of let me know what your initial impressions are.
So we have a patient with nausea and vomiting and diarrhea after eating some gas station cheese. I would probably think that could be, these symptoms could be associated with what he ate, but like I would ask more questions like, how is the diarrhea? What is the probably you gas station food? If how is the vomiting, the characteristic, and yeah, he has an elevated heart rate. And looking for the labs, we have like a leukocytosis, a hypochloremia, no inflammatory markers, no abdominal imaging was performed. Yeah, maybe we should do an abdominal imaging. What do you think, Yas?
Same thoughts. Like right now, I don't see lots of like heart rate is quite like mildly elevated, not that much. His mild hypochloremia might be due to the vomiting, depending how much he has vomited. Also, the leukocytosis up to 14 might be an infectious process, although that's I would say that's kind of stretch, because I mean he ate on a gas station cheese curds. It might have been like food poisoning. Although on a 92-year-old person, I would like to like get fluids, monitor, and also like try to see if he doesn't have something like sigmoid volvulus or something like that. Definitely see how that diarrhea is looking. So yeah, like let's see what's the next aliquot.
Yeah, so you go and talk to him, feels all right. He's just kind of nauseous. He's got lower belly pain, about the same since he got there. But his abdomen's pretty distended, and the patient agrees it's a lot bigger than normal. And he's very tender to palpation in the left lower quadrant. So I think your approach is great, like thinking of a few things that it could be and sort of rating them by probability in your head. You think you've got history that says this guy maybe got a hold of some bad curds. That also seems to be what the ED thought. They admitted and just put him on fluids for the nausea vomiting, just to kind of get him through this period of illness. But yeah, you also have a guy that has a history of arterial disease, and 92 things break down over time. So what are you guys thinking as far as sort of a prioritized differential, and what kind of questions are you trying to answer with ultrasound?
For me, I will try to see if there are any like I don't know how to say them, like the strands, like thickened strands on the USG. Also see if there is any sign of obstruction. Although we know that this person has a food poisoning, again, and a person, an elder person puts us on a, like, it's a frail patient. Like that's my situation now. Like it's a frail patient who's a food poisoning is going to affect him in a different way than a 30-year-old and a 20-year-old. Like maybe I can eat a cheese curd and I will have a really bad food poisoning and I will survive it. Maybe a 90-year-old won't do that. Like, so I will like try to ask him if if he has been passing gas, if there's bloody diarrhea, if he has like, if it looks like, how do they call it in English? Like jam, like in Spanish we call it like raspberry jam. I don't know if I translate it correctly.
Look at like currant jelly in this.
Yeah, current jelly, stuff like that. Because those are like emergencies. So like in the USG, I'm not very sure like the olive sign or like stuff like the, how do you look at that? How do you characterize it? I'm not sure how you say that in English.
Yeah, I think that's great. Yeah, you got it a few things there. And I'll be honest, I'm not super well versed with some of the intestinal ultrasound stuff. I'm accustomed to looking in people's abdomens, but mostly at right and left upper quadrants, suprapubic area, and doing like fast assessments or assessments for fluid, for ascites, that sort of thing. So I think my approach generally with this type of thing is to, the belly's really distended. I want to make sure there's not fluid or blood in there. And vitally, he looked pretty steady, and his labs weren't altogether concerning. So I think I might have time. But maybe the ultrasound gives me a better idea of other studies I need to order, or whether or not I need to contact my good friends in surgery. So my approach would just be to do kind of my normal abdominal assessment, right in upper left quadrant, and then kind of suprapubic area. And then I'm also going to scan the area where the patient is experiencing symptoms. So the left lower quadrant in particular. And so our right upper quadrant, I'll just kind of go through this quickly, but you got your diaphragm here. This is liver, and then kidney. We're looking the space between the kidney and liver, and also the caudal tip of the liver. Those are the areas most likely to have fluid pool. You can see your spine in the background here, and a negative spine sign as the diaphragm comes down and kind of erases it, so no fluid in that pleural space either. Left upper quadrant, we got diaphragm here, spleen, kidney, spine. On the left side, just under the diaphragm and above the spleen is the spot you're most likely to see fluid, but you can also see fluid collect here between the spleen and kidney, and I don't see anything there. So we go down to that focal area of pain, and now I'm like, whoa. What do you guys think of what we're looking at here?
Ravi, do you want to share what you're putting in the chat?
Oh, hi. We're looking at the bowels. So first we have to discern if this is small or large intestine. So the small intestine usually has the plica circularis. So the lines or the house sort of haustrations are circumferential, which we're kind of seeing here. And if it's large bowel, you see haustra, which don't circumvent the whole bowel. But here we're seeing those sort of projections, and there's a view there. We're seeing them going all around the intestine there. So I could say maybe a small bowel there, but it's moving. But if we just stop the image, or if we stop the probe from moving and we look for peristalsis, if there's lack of peristalsis, it could be ileus. But a lot of anechoic signal. I don't see stool. Maybe some stool in there, some isoechoic, hypoechoic. But it's anechoic, so it would be like fluid in there. What do you think, Scott?
Yeah, spot on. When I saw this, I wasn't really sure what I was looking at, but I thought I never see bowel that well, so it must be pretty distended. And there's something in it, right? So air generally doesn't transmit ultrasound. It sort of scatters the signal, and that's a lot of what you see in just sort of normal bowel. And sometimes you'll see like a little bit of particulate matter moving through there slowly, generally. And here I know I was kind of like moving around with the probe a lot because I was so excited that I was seeing this. But if you just sort of hone in, look for peristalsis, sometimes in a case of like a bowel obstruction or something, it'll be hypo or hyperkinetic. Depending on like sort of how far along it is and how severe. But yeah, so this bowel is looks dilated to me. 3 centimeters or more is generally dilated small bowel. And so it didn't include it, but there was another still image where I'm measuring the diameter, and there's a few spots where it's more than 3 centimeters. So this is more normal looking bowel. And again, this is my bowel. So if somebody sees something that they think I need to get checked out, just shoot me a message. But it should just be kind of flush with the peritoneal wall. And your intestine is all kind of bunched in there. And it shouldn't be real dilated. That peristalsis should be pretty slow moving. And you might see these little like white specks in there. That's little pockets of air bubbles inside of whatever fecal matter is there. And then sometimes you'll see like a little bit of gas kind of come through and give you that artifact where it sort of shines down. So, normal looking bowel in somebody who has no symptoms versus dilated bowel. It looks like it's not moving in a 92-year-old who's having vomiting. This is a more dramatic example of some abnormal movement inside of dilated bowel. So it looks like somebody like connected a leaf blower to an ileostomy, and they're just like shuffling that material through. This is right upper quadrant. We got liver here. And then this is bowel kind of pressed right up against the liver. And this is where the bowel sort of takes a bend right here. So you can see that material kind of going around that dog leg and moving back and forth. This is what we would call like a to and fro motion inside the bowel. And that gentleman wound up having a bowel obstruction. So I assessed him at bedside. He was still pretty well appearing, but I talked to surgery. They requested a CT, and we got a CT with and without contrast, and he had a pretty significant bowel obstruction and wound up with an NG tube, and then wound up on the surgical service afterwards. So the take-home message there is don't believe all of these gas station food propagandists. I love a good roller hot dog, and I would definitely eat cheese curds at most fine establishments on our roadways. I think that was the main cases. I just have one bonus case for you. It's an extra spooky one. I'm just going to blitz through it real fast. Room 700, couldn't feel his pulse. Says the nurse, temperature is 86 Fahrenheit. He tried to bite a care assistant, and they're asking for an order for restraints. So that's kind of peculiar. You look in his chart, and he's a 42-year-old guy, unknown history, no ID on him. Brought in by EMS, thought to be intoxicated, admitted for OBS until sober enough to leave. Last vitals were 12 hours ago, and they look pretty normal, with the exception of maybe a little tachycardia. CBC was normal. CMP shows a AST 300, ALT 100 with a T-billy of 3, and they did a head CT that was normal. That's all you got. And you just walk in and put a probe on him. And unfortunately, you got a rib right there, so there's a little bit of shadowing. This is a Plax view, and it looks like there's not much motion there. So you try a subcostal view, and it looks like there's not much motion there. And your parasternal short axis view, also, you're not really seeing much. The guy's just kind of moaning and groaning. And it turns out that this was patient 0 for the zombie apocalypse, and what you diagnosed was cardiac standstill. So you call the CDC and you put a bear hug around him because he's not dead until he's warm and dead. And then we tried to do some damage control with the burgeoning zombie apocalypse. Cool. Thanks so much for letting me share. If you guys want to follow any of the stuff that I do, there's my Twitter and site that badly needs updating, where I stashed some images from fellowship, and I read a POCUS literature newsletter every couple weeks on Substack. So thanks so much for letting me share, and I will back out of here.
Amazing. It was so great just you to make us go for 4 cases in 1 hour. That was absolutely perfect. Thank you so much for being with us. We are looking for more POCUS VMR in 2024. And do you have some teaching points that you want to let for us, Scott? Like 2 or 3 that you want us to remember about POCUS?
Yeah, I think with physical exam too, it's hypothesis driven. So I had a neurology professor in medical school who would say that he had made the diagnosis while he was taking the history, and then the physical exam was confirming what he already knew. And I feel that way about POCUS too. You know, sometimes I'm surprised and I see something I didn't expect to see, and that leads me down a different management pathway, like with that gentleman with the bowel obstruction. But oftentimes, based on my history and the data I've collected from the chart, and from other healthcare professionals I'm working with, I've formed an idea of what I think is there. And then I'm just using the POCUS to expedite management and to confirm findings that I expect to see. So I think it gets kind of a bad rap sometimes, because maybe we're just going in there and trying to like scan a bunch of structures, and then we aren't sure what to do with that information. But if you have a clear idea of why you're doing the exam and what you're going to do with the information on the backside of it, it's a really an invaluable tool. And it's hard for me to imagine practicing medicine without it at this point. And then my second piece would be if you work somewhere where you don't have a lot of mentorship, and it's difficult for you to learn how to do bedside ultrasound exams. You know, if you can get your hands on a probe, that's awesome. If there's a machine that you can use on the floor in a unit, I would recommend scanning patients that are already getting an ultrasound for some other reason, or who are getting like an echo. And then you can double check your findings against, against the gold standard, against that cardiologist's read of the echo, or against the radiologist's interpretation of that renal ultrasound. That's the way to get better at it, is to keep doing it on your patients as long as they're agreeable, and then kind of checking your findings against what the experts are saying.
Amazing. Thank you. Thank you so much for the cases and from all the learning. And yeah, we really appreciate it. I hope everyone have a happy Halloween, and I hope to see you all tomorrow. Bye, Dr. Scott. Bye, team.